Now, moving on to our next section, that is the major and the minor thoracolumbar spine injuries. In the first part, we'll be discussing the minor fractures of thoracolumbar spine injury. In the next, we'll be discussing the major fractures of thoracolumbar spine injury. What are the minor fractures? Which are actually, these are those fractures, although there is a fracture and there's a pain, but usually there is no canal compromise, the vertebral stable, and posterior ligamentous complex is very much intact. Therefore, there is no actually chance of developing neurological compromise later on as well. These usually include maybe the transverse process fracture, a spinous process fracture, which usually occur due to evulse with a sudden muscular activity. There may be isolated injuries and need more than symptomatic treatment, or this could be simply like fracture of the transverse process of L5 due to the possibly vertical shear injury at the pelvis. The vertical shear injury of the pelvis is when actually one half of the pelvis or hemipelvis is so much damaged that it actually translates upward. Now this can damage the transverse processes of L5 and may damage also L4 as well. But the problem is not at the L5, but it's the problem with the vertical shear. So you need to, that injury is more serious and needs to be managed with operative surgery. But probably L5 transverse processes usually does not make the lumbar spine unstable, therefore can be managed conservatively. Now this could be the fracture of the pars ventricularis. Pars ventricularis is usually at the level of L3, L4 or L4, L5, and this is actually connection between the two vertebrae in the posterior column. This may be associated with stress fracture if it is suspected due to back pain during the course of strenuous activities. Usually those athletes which have started running or weightlifting, and there may be a lumbar spine may be under more stress than usual, and they usually have this kind of a stress fracture or fracture of the pars ventricularis. Injury is often ascribed to the disc prolapse, but when you get an MRI, there's no actually disc prolapse which can be visible on MRI. For this, you may need an oblique X-ray just to see whether there is an associated fracture or there may be a simple non-union of the pars ventricularis. On isotope bone scan, usually it is a cold lesion. Rarely it's a hot, because if it's an acute injury, there may be associated with a hot lesion, but chronic pars ventricularis fracture, the stress fracture usually are cold lesions. CT scan is helpful, but it sometimes usually shows there is actually a clear-cut defect between the pars ventricularis as well. If you see the X-ray, this is the lateral view of a thoracolumbar spine. This is L5 and this is S1. Can you appreciate a gap between this as compared to the other vertebra? Similarly, on the CT, you can also appreciate this is probably some kind of a chronic pars ventricularis fracture, because this does not appear to be acute. Lines are very much demarcated. And if you appreciate this is the MRI, may or may not be associated with spinal cord compromise. So what is the treatment of pars ventricularis fracture? An acute fracture heals spontaneously, but unilateral pars fracture may need to go on to union with conservative treatment. Will require some degree of lumbar support in form of lumbar corset or lumbar orthosis. There may be you need analgesia as well, just to make patient pain free, so that as after 2 to 3 weeks patient can start weight bearing as well, and partial weight bearing and walking can be started. But if it's a pars fracture, if confirmed on CT to be chronic with sclerosis and cold on isotope scans, that will not heal on its own. This is important. This is actually a kind of a non-union of pars ventricularis. For that, you need a fixation as well, just to make sure that the canal remains stable later on. Now coming to the flexion-compression injuries. This is also called as flexion distraction injuries as well, in which there is actually initially axial loading leading to compression type of injury, along with the some forward displacement due to the overriding flexion of the proximal segment. Posterior ligamentous are usually intact. If interior collapse is marked, damage may be by distraction. When you're examining this patient, what you need to look at is the careful palpation of the spinous processes. If there is tenderness over there, there's possibly some kind of a pathology which is lying at the spinal cord. CT may show posterior part of the vertebral body fracture. There may be pedicle, lamina, spinous process may be intact as well, or there could be pain could be severe, but fracture may be very much stable. If you see this is the fracture, which is a compression as well as due to flexion type injury, but posterior ligamentous complex and the posterior column looks very much intact and stable. Now there may be the posterior ligamentous complex disruption as well, and there may be increased distraction of one vertebra over the other, leading to canal compromise, and there may be associated neurological injury as well. So the treatment depends upon whether this is an isolated injury and whether canal compromise is present or not, and whether there is associated neurological injury or not. So if it's minimal wedging and a stable fracture pattern, the patient can be kept in bed for a week or two until the pain subsides, and then mobilized without any support for the lumbar spine which is required. If there is moderate wedging with no instability, when we talk about instability, means the posterior ligamentous complex is actually intact. Patient can be allowed rest for up to 1 week. Wearing a thoracolumbar brace may be required. At 3 months, you get a flexion extension injury views. And why to get a flexion and extension views is just to see whether there is a distraction of proximal vertebra over the distal one or not. If there is no distraction of during the extension of the flexion, this means the posterior ligamentous complex is intact and there is no instability. If there is no instability, brace can be discarded, and if deformity increases later on, we may need to fix it, but for the time being, you do not need any surgery for this kind of an injury. Now, if there is associated, there are certain indications for surgery in this kind of an injury, especially the flexion-compression injury. If there is a loss of anterior vertebral height greater than 40%, according to some books and authors, it's 50%, but 40 to 50% loss of height and about 50% canal compromise is kind of almost an absolute indication that these fractured fragments which were causing the canal compromise and loss of height as well are not going to heal on its own, and they're going to lead to, they may be associated with later on neurological injury, which could be in form of a complete spinal cord injury. So something needs to be done, and especially regarding the fixation of these. Mostly if there is isolated only loss of height, we can do is simply a posterior fixation is preferred, that is going through the posterior approach, fixing the spine so that the height can be restored. Then height can be restored in form of the pedicle screws are fixed, and then they will be connected to the rods, and then destruction can be done over those rods. Therefore the height of the fracture is restored by use of those distraction rods. But if there is posterior longitudinal complex is disruption, posterior longitudinal complex gets disrupted, then there may be actually the fragments may be retropulsed into the canal after the damage of PLC, and this may lead to this that you may need to require direct or indirect compression. So there is not only distraction, you need to do some segmental instrumentation as well. Now coming to the axial compression and burst injury, which is isolated compression type injury without any flexion or extension. There is severe compression causing failure of the anterior vertebral column. This is more important, that usually the most common injury is the anterior vertebral column. Posterior part of the vertebral body may be shattered and they may lead to instability of the middle column as well. But what is important is whether there is canal compromise or not. Whether when the middle column has actually collapsed, that is the posterior 1/3 of the vertebral body has collapsed, these fragments whether they have retropulsed into the canal or not. If they have retropulsed into the canal with the posterior longitudinal ligament is intact, this can be restored indirectly as well. But if it has ruptured as well, then probably direct canal decompression may be required. Now these injuries are often stable, which is why, because anterior column is usually the most commonly affected, middle and posterior column remain stable, and overall canal stability is very much intact. On AP view, you see the spreading of the vertebral body. If you see over here, can you appreciate these are the interparticular distances, and suddenly this vertebra is actually collapsed. And can you see the distance between these two facet joints and these two facet joints as compared to other? There is definitely the vertebra collapses and spreads apart with increased interparticular distance and retropulsion of fragments into the spinal cord. On CT scan, the vertebral body combination can be clearly seen. There may be a retropulsion of fragments into the canal, which will be very much visible on the CT as well. And on the lateral view, if you see this is an X-ray as well, there is definitely wedge compression fracture anteriorly, and middle column is also involved. But we are not sure whether these fragments have retropulsed into the canal or not, because these are not very much visible on X-rays. That is why we need a CT as well as MRI as well. Now coming to the treatment. If it's a type A injury, mostly it's stable, but then we have to see whether how much retropulsion of fragments have gone into the canal. There may be minimal anterior wedging and fracture is stable with no neurological damage. If that is the case, the patient is kept in the bed until acute symptoms subside. Analgesics may be given. Patient is usually mobilized in thoracolumbar brace and body cast for about 12 weeks. And later on you get a flexion extension views. If all is okay, then the brace can be discarded and a patient can keep on doing the full weight bearing. If fractures involving more than 50% of the canal compromised, so that is a cutoff limit. If more than 50% is canal compromised, then either you need to do the decompression of the canal. Therefore, if the decompression is not done, this can proceed to complete spinal cord injury. Now that means the decompression could be indirect or direct as well. With increasing vertebral body combination, there is a risk of posterior alone fixation failure. Why? Because anteriorly, usually the first in these kind of a compression flexion injuries, what happens is, or flexion distraction injuries, that first there is a compression injury of the anterior and middle column. Now the anterior and middle column has already become unstable. When the distraction occurs at the posterior column, this leads to a ligamentous disruption as well. Now with all the ligaments not intact and if the osseous anatomy is also now unstable, we need to start not only just by fixing posteriorly. When we are fixing it posteriorly, we are only restoring the posterior column. The anterior column anatomy is actually not restored. Therefore, there is increased stress over the posterior column because the anterior and middle column are also unstable now. Therefore, that may lead to eventually the failure. So when this kind of a situation, all three columns are involved, you not only need to fix the posterior column, but also the anterior column in form of either graft or using a cage to put the graft in, just to restore the height so that the forces are evenly distributed and there is no failure of one column, because that is actually taking all the load and stresses of the movement, that is the flexion and extension of the spinal cord. Now coming to the treatment, the canal compression may be required, which could be direct or indirect. Now indirect means with the pedicle screw fixation and posterior distraction utilizing the intact posterior longitudinal ligament. The longitudinal ligament is intact, you can distract with use of pedicles, and longitudinal ligament will push back those retrosal segment from the canal back into towards the vertebral body. But if the posterior longitudinal ligament is not intact, then those will not be pushed back, and therefore you need to do direct compression. And then direct compression means going to the spinal cord through anterior approach and taking or removing those fragments from the spinal cord towards the vertebral body. And how to do it? If it's involving the thoracic spine, then going anteriorly would mean going through the thoracic cage, and that would actually may sometimes require the help of a thoracic surgeon as well. But if this lumbar spine, you can the lumbar spine, and these usually actually spine, arteries and major vessels are mainly in the retroperitoneal structures. Therefore, you can go retroperitoneally through the lateral incisions of the abdomen, and once from the retroperitoneal approach, you can go directly anteriorly into the spinal cord and do the fixation. That is called as the retroperitoneal or transthoracic approaches, and used for the anterior decompression in neurological incompetent injuries. Posterior fixation is through the posterior approach, and spinal cord is actually very much subcutaneous, so posterior approach is very easy. You just apply the incision over there and do whatever the fixation which can be done. But fixing spinal cord anteriorly is a bit challenging, and sometimes you require the help of a general surgeon as well as a thoracic surgeon as well, when especially we are dealing with a thoracic and lumbar spine. Now coming to the chance injuries, also called as seatbelt injury or jackknife injury. This is, as I told you, is a combined flexion as well as posterior distraction mechanism. What happens is the thoracic spine is hypermobile, lumbar spine is relatively less mobile. In deceleration injuries, the thoracic spine moves anteriorly or distracts us into flexion more quickly as compared to the lumbar spine, leading to a flexion distraction type of injury at a thoracolumbar junction, which is called as jackknife injury as well as seatbelt injury. There's little or no crushing of the vertebral body, but they may be associated with the posterior and middle column fail in distraction. Why? Because there is massive ligamentous or osteoligamentous injury. This may be associated with neurological damage as well, and usually it's unstable. Now coming to the diagnosis can be made by x-rays, which may show horizontal fractures in the pedicle and transverse processes. There may be an apparent height is increased. Why? Because there is actually the loss of posterior ligamentous complex. There's opening up of a disc space posteriorly, which would also indicate that there is opening up of the posterior ligamentous complex. And in purely ligamentous injuries, vertebra may look normal, but there may be abnormal findings over the MRI. Coming to the treatment, this important point is mostly they are unstable, and whatever it is, it's usually only and only if it appears to be stable and it's tested, then only you can go for conservatively bed rest and bracing. But if it's unstable, it requires posterior fixation and allows early mobilization. Ligamentous or chance injuries need posterior instrumentation fusion. That is, you need to go from the posterior portion of the spine, fix one segment above and below, and so that let the injury which has actually happened, the osseous ligamentous complex, at whatever level it is, let it heal over a period of time by immobilizing it through the posterior instrumentation. Now coming to the fracture dislocation, this is the classical type 3C injuries, which is segmental displacement with various combination of flexion, compression, rotation, and shear injuries. And all three columns are actually disrupted. Spine is grossly unstable in both the coronal as well as the sagittal planes. If you see this X-ray, you can appreciate translation in the AP view, that is the coronal view, and if you see the lateral view, this is also grossly unstable on the sagittal plane as well. Coming to the treatment, the surgical stabilization is often necessary, both anterior as well as posteriorly. And fixation requires two vertebral level instrumentation above and below. Why? Because we need to have a very large fracture segment, we just need to make it stable. Neurological outcome is actually mainly determining whether at the time of injury there was a complete spinal cord injury, whether it's a partial injury. Depending upon that determines what type of neurological outcome. If it was a quadriplegia or tetraplegia at that time, or even a paraplegia, that means there's usually very less chances of recovery later on despite the fixation. In this section, we have briefly gone through the thoracolumbar spine injuries, mainly the three mechanisms, that is the flexion injury, flexion compression injury, and then there is the flexion distraction injury, which is a type B injury, and type C injury is actually in which there is compression, flexion along with the shear, rotation as well as translation. What is important is when we are viewing this, we need to make sure whether first define whether this is a stable injury or unstable injury. If it's an unstable injury, it needs fixation, and mostly posterior fixation alone will not help because it will put too much stress on the posterior elements. So you need to fix both the anterior as well as the posterior column for a more stable fixation, especially in the case of the type B and type C injuries. Thank you very much. Keep watching sqadia.com.